Good afternoon, everyone. This is a very exciting day. There's a lot of new information that you will have available to you. And what I wanted to do this afternoon is just share some highlights from our department's budget, the future Department of Mental Health and Addiction Services, and then direct you to websites where you can receive additional information related to the governor's budget rollout today. So as you may have learned earlier this afternoon, Governor Kasich has 5 key issues in the budget, and Medicaid and health care for individuals who lack health care today is one of those key priorities. There are 3 priorities on which I'm going to focus this afternoon, and they're related specifically to our budget. Number 1 is extending Medicaid coverage to 138% of the federal poverty level. That includes steps that will be taken to simplify and modernize our overall eligibility system for the state of Ohio. The second one is a package of initiatives that we're calling Recovery Requires a Community, that focuses on helping individuals who are under 60, have mental illness, and are living in nursing facilities to transition into a less restrictive setting if they desire to do so. So I'll be talking about that today. And then finally, in the context of our consolidation between ODATIS and mental health that's anticipated on July 1st, we have a downsizing of our administrative footprint, and we want to take those resources and invest in something that will be meaningful from a service perspective to the field. And so I want to talk a little bit about that as well this afternoon. Okay, next slide. We're working to advance the slide, just one second. Being the recovering budget analyst that I am, I think that it's always helpful to start with the numbers. For GRS, our department's budget, when you take into account the ODATIS and mental health appropriations for fiscal 13, and then relative to the consolidated department next fiscal year, is essentially flat funded. In both years, from an all funds perspective, I wanted to call to your attention that there appears to be a significant decrease, but that decrease is actually related to the fact that Medicaid claims are running out of our system and continuing the transition to be paid by the single state Medicaid agency. And so this is a decrease on paper only and has no impact on services available to individuals throughout Ohio. So just wanted to call that to your attention. With that said, though, with our basically flat funding in terms of appropriations, we do have 3 new investment opportunities that I wanted to talk about today. And those are the 3 items that I highlighted just a second ago. Before we move on to that, I thought it would be helpful to just share a little bit of the foundational work that is underway in this biennium that is helping to prepare us for fiscal years 14 and 15. So first of all, the impact of Medicaid elevation to a state-level responsibility is key in our ability to now support the governor in his proposal of a Medicaid expansion. If Medicaid had remained a local commitment and local resources were tapped out in some areas of the state, the ability to move forward as a single entity and expand healthcare options for folks would not have been possible. And so elevation that occurred in this biennium, I think, is a key foundational piece to the expansion proposal. The next item that is really foundational is the creation of Medicaid health homes for individuals with severe and persistent mental illness. As you're aware, this was a key priority expressed by the governor in the fiscal 12-13 biennium, and we are now in the middle of implementation. We've got 14,000 folks approximately enrolled in 5 counties in Ohio, and we anticipate that we will be offering the service to individuals statewide by July. So that's very exciting news, and I would suggest that you take a look at our website for updates and information on an ongoing basis. but really the integration of physical and behavioral health care is really key to improving outcomes and managing costs as a Medicaid system in general. And so this was a very important foundational priority as well as we go forward into this next biennium. And then finally, some steps have been taken in this biennium to assist in the restoration of funding for addiction and mental health services. There's been, over a lengthy period of time, a period of atrophy for services, both state, federal, locally, and the governor has taken some steps to remediate that. In the context of an $8 billion shortfall in the last budget, that was difficult. I think that the expansion of Medicaid is, will be huge. But there were some steps that were taken in this biennium that I wanted to just note because they're significant. Number one, the $10 million commitment to community capital for mental health, and we said we were going to use the vast majority, if not all of that, for housing. As you're aware, as a consolidated enterprise with ODATIS going forward, we are going to be expanding our housing philosophy and examine ways that we can incorporate recovery housing and different sorts of opportunities there on our continuum of care. That's going to be something that's evolving into the next biennium, but we feel that the infusion of resources for capital was really important and a very positive step this fiscal year for us. Also, in the governor's mid-biennial review last spring, both departments had an infusion of approximately $3 million of additional resources for treatment support, so that was very good. And then just a few weeks ago, we announced $5 million that we will be coordinating in concert with the Department of Developmental Disabilities to support youth and families who have very complicated circumstances at home due to assaultive behaviors or other sorts of threats of violence. And so we're going to be working with the field to identify a specific plan forward for the use of those very, very important resources. So moving on now to the first of the priorities that I really wanted to highlight for the fiscal 14-15 budget is the expansion of Medicaid. And there are plenty of items available to read more about this on the Office of Health Transformation website, and that link will be available at the end of the PowerPoint presentation just for your reference. But there is great benefit in making this sort of investment in concert with the federal government because it helps people obtain and maintain employment if they have health care, helps to have more tax-paying citizens, and just increases the overall health of our public here in the state of Ohio. And so there are a lot of very tangible benefits. We are able to use the federal resources that would otherwise be directed to other parts of the country here in Ohio for the benefit of our own citizens. And we also are supporting businesses, healthcare industries in Ohio that otherwise would not have the ability to receive revenue for providing services to folks who are currently covered through our safety net. So there are a lot of very important business drivers to contemplate in the Medicaid expansion decision. We think that ultimately we will see more than 366,000 folks enroll, and this slide here shows some examples of the types of Ohioans who will now have access to services, including behavioral health services. Parents who are struggling, who are above 90% of poverty, which is the current eligibility threshold for Ohio Medicaid, childless adults who are struggling with addictions and that prevent their ability to work, folks who are coming out of prison, and others who really are challenged in some cases to identify and achieve coverage for just some basic health care needs. Thinking about the behavioral health system specifically, we estimate that approximately $70 million annually, once the expansion takes full hold and is fully implemented, approximately $70 million annually that is currently funding or being funded through the safety net will be funded through Medicaid. And that will enable local ADA boards to redirect resources to other sorts of recovery support using state and local and federal dollars. Things like housing, employment, things that are very key to making recovery a reality for folks in all of our communities. We anticipate, though, that because of the Medicaid eligibility not being possible until January 1st of 2014, which is halfway through the first year of this biennium, and then the take-up rate, that it'll take a little time for folks to enroll in Medicaid and then begin to receive services through Medicaid. We anticipate that for this first biennium, it will be about $105 million that is able to be available for redirection sometime during the course of this biennium. Now, clearly, none of this is happening on day one. It's going to take some time, but we think that the ability to have Medicaid as a clinical payer source for some services that are today funded through the safety net system, publicly funded in Ohio, will offer some opportunity to build other areas where we know there are gaps, long-standing waiting lists for other kinds of services. So this has a lot of value for us throughout the state of Ohio. The next topic that I'd like to discuss with you this afternoon is the second initiative. We're calling this Recovery Requires a Community. And this is focusing more attention and more actionable strategies on a population that sort of comes to light in newspaper articles, or we become aware of anecdotally on a not infrequent basis. But we've not taken many steps in concert to make a lot of change in the past years. And that's folks who are under 60, living with mental illness in nursing facilities. We think that supporting folks who have expressed interest in transitioning back into a community-based setting and making sure that services and supports are available to support their choice is really important. It's consistent with the federal Olmstead decision. It is less costly for taxpayers, and from an outcomes perspective, it really, does more to support the concept of integration and wellness for individuals. So we have a goal that is articulated in this budget that we will move approximately 1,200 folks at their these are folks who have indicated an interest in moving from nursing facilities into the community in this biennium. So the estimate specifically is that we would provide transition assistance for 500 folks approximately in the first year of the biennium and 700 in the second year of the biennium. So we could always exceed these goals if we're working very successfully. Our waiting list information indicates that there certainly is at least this level of interest, and so I think we've got plenty of work to be done here in concert with all of our community partners across the state. So how will we do this? As I noted earlier, we do not have additional appropriation built into our budget numbers in the as-introduced budget, but we will have temporary language in the budget bill that allows us to work in concert with Ohio Medicaid. And as we transition folks from nursing facilities into the community, Medicaid will make a financial transfer to the Department of Mental Health and Addiction Services that we can then use in support of a number of objectives in this area. So I'll talk about that just a little bit here. We are trying to the extent possible to maximize our use of a program called Home Choice, which is Money Follows the Person, is the federal demonstration program. And that offers 365 days of additional support to individuals who are leaving eligible institutional settings. So nursing facilities, institutions for ICSMR for the intellectually disabled population, and some hospital settings in certain circumstances. And so we're going to use Home Choice as a vehicle to provide some additional tools for resources for these folks we've had a lot of success in the last 20 months or so using home choice for this specific population. Actually, we've moved more than 600 individuals from nursing facilities into the community in the last 20 months, and in the last 12 months, we've moved more than 400 people. So again, this is at their expressed interest in moving to a community setting, so we're not trying to transition individuals who do not want to be transitioned. But so we're using home choice when possible. When an individual is not eligible for home choice, we want to stand up a sort of parallel approach that would allow us to assist them as well. For example, if you're moving out of a state psychiatric hospital that is not eligible for home choice, you would have an opportunity to move into a community-based setting. And so we are doing an access success 2 is what we're calling this, to provide some resources for individuals who are not eligible for home choice to have the same kind of general opportunity. So thinking about specific strategies, we would like a portion of the resources that are cost avoided from Medicaid to be used in the community for specific non-Medicaid services and supports for the specific individuals who transition. So if housing is a barrier for Tracy Plouck and Tracy elects to leave, there could be some resource available to support housing, just as an example. Engagement with maybe peer support services. That is not something that's on the Medicaid state plan at this moment. Until it is, that would be another sort of opportunity that could be funded using these dollars. We also want to use a portion of the resources to support settings where folks might go or are living now that augment the quality of life for people who could be in similar circumstances, but for the fact that they're already living in the community. And that brings us to the adult care facilities. We have more than 700 of them in the state of Ohio, and what we would like to do with a portion of this cost avoidance is to actually establish a program whereby we could provide some incentive dollars to adult care facilities who can attest that they're connecting folks who are served in their settings with Medicaid health homes or with appropriate case management in the systems in which their residents are engaged for services. So this is a way that we can, at the adult care facilities option, provide some incentive resources that really help rise the overall tide, because folks are then being connected with the services that they may not be connected with today. Let's see. And in so doing, we would continue the existing residential state supplement program. We're also going to be stepping back in the first 6 months of this biennium to look at how we're funding adult care facilities and how we're funding the RSS program to see if some changes are warranted and if there's opportunities there, which we believe that there are, that we could sort of advance the ball in that general provider area as well. This may or may not require statutory change. I think there are some options that we could exercise that actually would not require statutory change. We also want to establish a strategy called Recovery Requires Housing, which would provide some limited voucher services for housing if housing is the specific barrier that is being experienced by the individual. For example, I mentioned adult care facilities a minute ago. If the adult care facility has more than 4 beds, that is not a placement that home choice will recognize federally. So there may be cases where a person is electing to leave a nursing facility and they want to go to a specific licensed setting. A voucher that could be flexible to support their choice could be used there in a cost-effective, healthy, safe setting that would be helpful to overcome the housing as a barrier. So I think we want to have some degree of flexibility, but the gap is where people do not have sufficient income to provide for their housing, and the general threshold is we don't want to see more than 30% of a person's income go for housing. So this is something something that we're interested in demonstrating, and this will grow as we are able to move more folks and cost avoid more resources from the Medicaid program. The final strategy that I wanted to highlight related to recovery requires a community is the hospital exemption. As you may be aware, if an individual is moving from a hospital setting and discharging, they can go to a nursing facility without having a pre-admission screen conducted to determine if the nursing facility is the most appropriate setting. If, for example, if they have a diagnosis related to mental illness, they may not be necessarily, nursing facility may not be the most appropriate setting, but because there's a hospital exemption today that applies to all hospital units, people can go and then we'll rely on a resident review to, discern the validity of their needs relative to their placement. What we are proposing in this budget is for psychiatric hospital units, whether they're state-run or private, we remove that hospital exemption. So anyone who is presenting for services in an inpatient psychiatric setting who then is moving to a nursing facility upon discharge will have to go through an assessment. It doesn't mean that they are not going to be able to move to a nursing facility placement, but it assures that we are assessing every person who moves into a nursing facility who has a significant mental illness challenge or diagnosis before they actually move in there. Again, if a person is determined to not be appropriate for nursing facility placement, we've got some other tools that we've identified that we can draw upon, such as the housing voucher concept, to make sure that no one is being discharged to homelessness. So, I think all of these work together, and we're going to, I'm sure, learn a lot on how we can best coordinate these as we go forward. I want to move now to the third initiative that we wanted to highlight today for you in our budget, and that is one of the benefits of the consolidation. As you're all aware, we will be a new agency effective July 1st, and in becoming the new agency, we've been able to negotiate that we will not have to do any staff layoffs related to consolidation, which is very positive. However, as positions become vacant, we will not be filling all positions because we've got a broader team and we can use our resources a little bit more flexibly. Also, we will be buying certain kinds of services differently from an administrative perspective. So instead of having 2 license arrangements with a vendor, we now have 1. So we'll have some additional economy in terms of our procurement. We've also are looking at some ways that we can more strategically fund some initiatives within central office. So all of this we anticipate will result in approximately $1.5 million of less need for administrative spending in GRF in both fiscal 14 and fiscal 15. And because one of the demonstrated objectives of this consolidation was to actually become more centered on the client and what we can do to support individuals who are receiving services in the system, we thought it was really important to take those cost-avoided resources and redirect them into services. And so for each of the fiscal years, we have a new GRF line item that's called Community Innovation. It's funded today at $1.5 million in the as-introduced version of the budget. The goal of this line item is to make targeted investments in initiatives where we think that a little bit of funding infusion will help improve outcomes, reduce spending elsewhere across the state of Ohio, whether that's a local system, another state system, et cetera. And so this is not a series of resources that are going out on a formulaic basis across all communities in Ohio. Rather, these are going to be some targeted demonstrations. And what we would like to do in this first biennium is to focus on the intersection of addiction treatment and mental health treatment in jails or in concert with law enforcement, because we think that trying some new things there will have the effect of actually improving folks' outcomes locally, hopefully reducing recidivism, and reducing overall taxpayer expense, regardless of whether you're talking about local, state, federal, all together. So we anticipate that later this month we will be announcing some specific demonstrations that we would like to undertake with these dollars, but they will be focused on partnerships between law enforcement and addiction and mental health providers and the global system. So that's exciting. And then, you know, assuming that we are successful in these endeavors, I think that then helps to make the case for some additional advocacy in this area as we go forward, and thinking about, you know, the additional recovery resources that may become available through the Medicaid expansion, you know, taking a hard look at whether some additional strategies in this area make sense. The line item, though, is sufficiently flexible that we could focus on other inter-system projects as well, not just law enforcement. Well, we thought this was a very logical place to start because we've been in conversation with the Buckeye State Sheriff's Association for probably about 9 months now, and we've got some great ideas. All right. So we anticipate that our budget will be, the budget bill will be the vehicle for our consolidation between ODATIS and mental health. And you will see a lot of language changes if you're someone who enjoys reading budget bills related to ODATIS and mental health. We are not changing everything that's in there, but rather we are you know, streamlining our code so that we're reflective of a single agency. We've had a very transparent process with a host of stakeholders to say we really only want to make changes if it's directly related to consolidation, and we've been very public about what it is that we're doing. So, but I anticipate a lot of volume as far as, you know, seeing our language, because anything that got moved also is in the budget bill. Let's see. Okay. Go to the next one. So, opiates continues to be a significant priority of Governor Kasich, and Orman Hall is here with me today. He will continue to spearhead all of the opiate initiatives for the state of Ohio. The governor's opiate action team will continue to be the general governance vehicle, and there's a lot of really cool things that are unfolding today and will be continuing as we go forward. And so we have a white paper that's been developed that will be available on the website later today, I believe, related to this. And so I encourage you to take a look at that. We also, you know, continue to run 6 hospital sites around the state of Ohio. The budget does not really entail significant change for those facilities. We've done a lot of work in the last 2 years to improve what we call the system of care, to compare best practices between the sites and focus on overall improvements to access and safety and clinical care. So that work will continue. One item that I wanted to highlight for you, just as an FYI, we are embarking on a shared services arrangement in partnership with the Ohio State University Medical Center to have them host our electronic medical record for the hospital. And we see this as a great opportunity to better leverage resources that are publicly funded in the state, and also, you know, improve the quality of the care that we're able to provide for our patients. We also have collaborative work underway that is not really, you know, featured significantly in the budget, but it remains a core point of focus, and that's related to the evolving challenges that related to gambling addiction in the state of Ohio. And we have a plan that is under development today, and as the casinos and racinos continue to, I guess, be established in Ohio, you know, our effort will be ongoing related to treatment and prevention supports related to gambling. So those were the major items that I wanted to highlight for you today. There is much, much, much more available, and so this last slide contains some websites that you may want to examine. You may have seen the governor's streaming video from earlier today where he highlighted the overall budget, and I've personally not had the opportunity to digest everything, so we'll look forward to doing that, but there's a lot of exciting change being proposed. Also, for those of you who may be unaware, the OBM website, the Office of Budget Management, has a blue book that you've got a drop-down menu. You can go to any state agency about which you're curious and see an overview of their specific portion of the budget. And so that might be a resource if you're interested in changes related to child welfare or rehab and corrections is something that we haven't touched upon today. The transformation website, health transformation, all of their materials, I believe, are posted at this point, and they've got probably at least 8 or 9 white papers on different topics that may be of interest to you, different areas of Medicaid reform or the expansion proposal, certainly. And then all of our budget-related information is being split up. It's actually up there now on our consolidation website. Thinking forward that we're going to be a new entity, we put all the budget stuff there, and if you go to the ODATA's website or the mental health website, it will direct you to the consolidation website. So that's there for your reference. And then, as always, we encourage you to join the e-news listserv. That's where you can get regular communications from us, as well as anything that might be a hot topic that's just popping. We make sure that we push that out, and the communications team has done a fantastic job in bringing together all kinds of distribution lists so that we've got an effective mechanism for communication. I think we have some questions here that I may or may not be able to answer, but before I do that, there's one other item that I wanted to highlight. As you are looking through our budget spreadsheet, if you have inclination to do that at some point or when the bill comes out, you will notice in the residential state supplement line items, it's what looks like a significant increase between fiscal 13 and fiscal 14 for the RSS program. And that's a supplement for folks who are living in licensed settings. What happened, though, there is a net zero increase between this year and next year, but we merged some line items. So 2 line items where a portion of the funding had been is now in a single line item. So it looks at first blush like there's an increase. There is not. I talked about some of the other investment strategies we have related to adult care facilities, but that was one point that's already come up that I just wanted to make sure I clarified for you. All right. We have no shortage of questions. So the first question is, will the PowerPoints be made available? Yeah. Oh, you've answered that?
We answered that, and that was sent out to everybody during this. That as Tracy just talked about, it's at the consolidation website, and you click on budget.
With the expansion, would previously Medicaid ineligible clients now have access to health home services? Lauren, we have definitions of individuals who would be eligible for health home services, severe persistent mental illness. So I think that not all individuals who would be enrolled in Medicaid as a part of the expansion, but some element of them would be if they meet the criteria. So you can look forward to more information on that. As an aside, in a weekly email communication related to health home implementation. And so look forward to that. I'll just offer that little commercial public service announcement. But that's the sort of thing that as we meld these 2 initiatives together, we'll want to make sure that we are clarifying appropriately. Alan Johnson, since mental health is flat funded, will you be able to meet any more of the critical service needs? Alan has left, apparently, the conference call, but the thinking is over time, the infusion of Medicaid as a payer for the clinical services will make available some dollars locally that could be spent for other recovery services that are not clinical in nature. So housing, family respite, whatever is sort of the priority locally, that could be made available. Now, in some communities, there's not a ton of resource that could be redirected, so that that would remain an ongoing challenge. And these resources will not be made available early in the biennium. They will be further downstream. So that would be another related challenge. But I think on the whole, there are very positive opportunities for non-Medicaid in this budget generally, once you get a little bit further into the biennium. Next question, would clients at the health home be required to front the copay for non-emergent care delivered in emergency rooms per the governor's proposal? Lauren, your question is of a sufficiently granular nature that I think I would prefer to defer that. I think we can maybe put that out on an FAQ or some follow-up. I just would not want to provide the wrong answer in this setting, since we now have, can't see how many people are now on, but numerous 340 folks. So let us get back to you on that. We can have an answer. I just do not have it. Yes, there's a reminder from Liz Gitter in our office that home choice can be used for children and young adults with some resources for community transition. So there is Liz, I think what you're referring to here, there's a pot of resources associated with the Ohio Medicaid program that offers some additional assistance as folks are coming out of institutional settings, and including potentially residential in some circumstances. And so I suspect that that's the reminder there. Okay, the question from Pam Wade up in Cleveland. Will the strategy of wealthy individuals transferring their assets to children to qualify them for Medicaid be addressed? Many elders and their families could contribute to long-term care expenses. I've heard of physicians, lawyers, and others who've had their parents in long-term care on Medicaid. This is an unfair tactic. It increases the cost to the state. Pam, I don't have specific information on whether there's initiative related to this in the Medicaid budget proposal. However, having served in Medicaid a number of times, I know that this has been under discussion, in previous years. And so I would actually refer you over to someone in Medicaid, or take a look through their budget documents. I know they've got a white paper out there that goes through a number of Medicaid-related changes. So I don't have the answer to that, but I think you could find the answer. Who administers the pre-admission screening and resident review? We have a unit at the Ohio Department of Mental Health that administers a portion. The first screen actually is conducted locally by the area agencies on aging, and then the Department of Mental Health also has a vendor that works with us on a select number of the cases as well. So it's a phased assessment process. The next question is, will local boards need to merge as well? We have no requirement in this budget for any local boards to merge or to consolidate. We've said all along that our political interest is not in seeing boards merge or not. It's a local decision. It's local governance. However, if boards elect to come together, we would want to be supportive of them. So we do not have a dog in that race in this budget or in general. Next question. As the departments are consolidated, can treatment also be merged, allowing treatment for both psychiatric and AOD services, as well as some blending in for licensing of staff and units? Pam, this question I think is an important one, because our consolidation actually affords us the opportunity to take a look and say, how can we be a little bit more customer service oriented to the providers, service oriented to the clients who may need both sorts of services. And we've got a team of staff who are working at looking at whether there are some regulatory changes that might make sense at this juncture. With all of that said, though, there is no movement afoot to require any singly certified agency to become a dually certified agency or anything like that. I think we've got opportunity, and we're actually exercising opportunities now to think about how we could be a little bit more comprehensive in our approach if it is warranted between the two systems. So, for example, we have patients who discharge from our state hospitals who have opiate dependence, and we could have better coordination between the state entities, state staff, local entities, and we're moving forward to look at some strategies in that regard. So I think it's situational, but this is absolutely the time to be, if you've got an idea, to come forward. Next question. What is being proposed to address the growing deficit in providing mental health services for children, particularly within school settings. This is not a question that is specifically addressed in a strategy in this budget. However, we've got folks really from both the existing ODATs and existing mental health departments who are looking at how we could be approaching things better and differently in concert with providers and looking at overall capacity. So I don't feel like I have a very comprehensive answer for you. We do have the $5 million that the governor has announced. That is not specifically directed to to be used solely in a school setting, but I would say that partnerships with the education community is not off the table. So, Greg, if you want, get linked into those discussions, and that might be helpful with your question. Next, please elaborate on specific services paid with local levies that Medicaid will be taking on under the expansion, and what other services local dollars can pay for as a result. To the extent that a local ADAM board is paying for services for an individual who might be a childless adult up to 138% of poverty. It might include things like med-somatic, case management or CPST, partial hospitalization perhaps, assessment to the extent that the person would be Medicaid eligible, intensive outpatient treatment on the AOD side. Really, and actually I would reference the OACWA, the Board Association, just put together a nice schematic that shows how Medicaid and non-Medicaid services, as they're currently defined, interact together in support of an individual who has needs that are both Medicaid and non-Medicaid. And so I believe that is posted on their website if you wanted to take a look at that. Examples of services that Medicaid does not reimburse that would be, I think, maybe in a sharper focus locally would be items like housing, employment or employment support, peer support, respite sorts of services. There's really a laundry list on the non-Medicaid side as well, but those are some examples. Next question, will the audio portion of today's webinar be available on our website? Corey, actually, if we are successful, the answer is yes. We're really leaping into the 21st century. I think this hour is being recorded and will be made available probably by tomorrow. People are looking at me like, Tracy, did you just say that? But I think that's going to happen, assuming that we've recorded this successfully. So yes. Esther, I have no doubt. I will no doubt have questions, but my guess is many will be answered on the OHT website. Already read the one that came out. Just let me say how refreshing it is to see progress being made. Thank you to the 21st century. Move into the 21st century finally. Thank you. Yes, thank you, Esther. We have no shortage of things underway, but I think it's a really exciting time. Mike, is it correct that there are no new funds and increased activity to move people back to the community with increased responsibility? I am a little bit at a loss as to what you mean. There is no additional appropriation in the executive budget related to the continuum of care line item. However, we have the ability through Medicaid expansion to infuse some additional support for clinical services that are not available today through the federal funding of Medicaid expansion. We also have negotiated an arrangement with the Ohio Medicaid that as we move folks from nursing facilities into the community, the cost avoidance associated with what would have been their Medicaid nursing facility services will be moved over to our system for non-Medicaid support. There's not a budget number in the bill as it will be introduced because I think it is ours to demonstrate our ability to make progress. And so amounts will be hereby appropriated based on the number of folks who were able to effectively transition. So if I didn't answer your question, just call me later today. Will Health Home expand to substance abuse? We are trying to establish the Health Home so that in this first phase, the Community Mental Health Center as the lead is also engaging substance use agencies to the extent that they are not the same in that community. So we would continue to encourage collaboration to occur. At some point in the future, we will have a next phase of Ohio Health Homes that will not be focused as a primary on individuals with severe persistent mental illness, but rather on other sorts of chronic conditions. And so individuals who have substance use disorder could be enrolled today if they also have a co-occurring mental health challenge, or they could be enrolled, with other sorts of physical conditions in a later phase. So I hope I answered your question there. If not, follow up with me. Patrick, will the incentive funds targeted at partnerships with law enforcement and jails include collaborations with agencies that serve youth with co-occurring disorders and juvenile justice involved? Patrick, that's a good question. That's certainly not off the table. We are working to examine opportunities for specific demonstrations now, so I would encourage you to actually contact Dr. Mark Hurst, who's sitting here nodding at me. So just contact Mark, and if you've got a specific demonstration to suggest, now's the time to have the discussion. Let's see, those redirected funds for supports will be regulated by local boards, correct? To the extent that I assume, Denny, that your reference is related to Medicaid expansion, to the extent that the board is the entity that is currently funding the clinical safety net service, and the safety net service will be picked up by Medicaid, it will be the board's resources that will be available for redirection. So that would be at the behest of the board. So hopefully I was clear there. So I think the answer is yes. Next question, will all clients fall into a managed, can you move the cursor? Will all clients fall into a managed care plan? Esther, as you're aware, we are working with the health transformation on the integrated care delivery system, which sometime this fall is expected to enroll folks across, I think it's 14 counties, who are duly eligible with Medicare and Medicaid into a managed care arrangement. And those communities that will have enrollment have already been designated, and the plans have already been identified, the specific options that folks will have. We have statewide Medicaid managed care for many populations today. That will continue, and also the children who have disabilities in the ABD category of Medicaid will be enrolled in managed care pursuant to language that was in the last biennial budget bill. Other than that, I'm unaware of any change of status. So, largely, there's, to my knowledge, nothing new to announce on that front. Next question is from Doris Jacobs. Because adult care facilities will be a more viable solution to housing, will the qualifications change for operators? Doris, what we said when we took over the regulation of this program or series of programs about 18 months ago was that this was going to be an iterative process. We were successful in partnering with the Ohio Housing Finance Agency this year to administer $1 million from the Housing Trust Fund that did some critical health and safety repairs for, I believe, 115 of these facilities, and that work is underway because we thought as regulators it would be important to help folks get a leg up if they were interested in making some improvements. And so I think we'll continue to look for opportunities like that in the future. We have made statutory changes in the mid-biennial review that would better align how we are approaching HCF regulation with other licensed settings that we regulate. The rule work is still underway in this area.
It is, and there's also, we were trying to get another change in the upcoming budget to just consolidate the different types. There was sort of something out there that was going to complicate it.
So that is underway. I think that this is going to continue to be an iterative process as we go forward. Bill wants to know, what are the key opportunities for communities to expand housing opportunities with this budget? Bill, I'm not sure if you were on the call earlier today, but or the call earlier in this hour, but what we said is we want to establish a limited voucher program that would help specific individuals who are challenged with substandard housing, homelessness, moving from institutional setting, to the extent that of ways across Ohio, but I think you know that we have an ongoing commitment in this area, and we're always looking for opportunities where we can take some steps. So we've got this limited voucher that we would like to stand up, and we will continue to work with our partners from OPA and other areas to look at how we can do more in the area of housing, including preservation resources. So look for, that's a little teaser, look for an announcement on that soon. Next question is from Colleen McKenna. Will the state be offering an RFI for the piloted programs under community innovation for cooperative efforts between the behavioral health providers and criminal justice providers? Colleen, the answer to that is most likely no. I think we've been looking with the Sheriff's Association, the Board Association, providers to say, okay, what are the major challenges here? And I think, you know, the challenges are pretty clear: access, resources, et cetera. We're interested in looking at some demonstrations that might help us to build capacity between communities using telemedicine, looking at some infusion of resources around case management. So we have some ideas, but candidly, $1.5 million is really not enough to do a whole lot in many areas of the state. And so we think if we have a few targeted demonstrations that help move the ball forward in some communities, that will help make the case for some additional work in this area. So if you have specific suggestions, at the risk of him throwing a chair at me, I would suggest that you contact Mark Hurst, because I'm also telling 340 other people who have my ideas, are hearing it also. But now's the time for us to really be hearing what some creative strategies are. Okay, next question from Jackie. Will any of the specified funds be used for recovery support services? Jackie, I am not sure which specified funds you're referring to. I think for the community innovations line item, which we just discussed, the expectation is absolutely it would be both AOD services and mental health services, to the extent that resources are ultimately available to be redirected for other kinds of recovery supports as a result of the Medicaid expansion. That absolutely would also include recovery services related to substance use disorders. So short answer, yes. Question from David Ross, who's left, is our Family and Children First organizations flat funded? I believe the answer to that is yes, although I don't have that immediately in front of me. Charlie Ness, if there are no new funds being made available for mental health and AOD community services, and given that all previous discussions about allocations were attempted to address historical funding disparity between board areas through the use of new dollars, will there now be a redistribution of existing funding among board areas to address that disparity? That was the longest question that I've received so far today, but my answer to that is no. I think we have had transparent and very productive conversations with the field generally about if another dollar is available in the continuum of care line item, how should that be dispositioned? And we have talked about new resources. I feel very strongly that to take from one area and provide to another because a disparity exists is problematic. So we don't know what efficacy is going to entail. We may well have additional infusion in the continuum of care line item before June 30th arrives, but we don't know that. But in the interim, unless, in the interim, my position hasn't changed on that. Michelle Bays, will those who are credentialed and LICDCs, et cetera, going to be warranted the opportunity to be credentialed mental health clinicians due to the merge and vice versa? We are continuing to evolve work around our role as a regulator. However, I'm not sure of the status of the discussions with credentialing boards, and there is not any attempt to sort of meld everyone into the same, recognizing that some people only want and want to have an AOD specialization or only have a mental health specialization. And so I don't feel like I have an incomplete answer to that question, but I can actually we can get you connected with someone who can answer as far as what the status of the discussions are. So can maybe somebody make a note of, Michelle, I'm not sure where you are from, but if you want to maybe contact our consolidation website at consolidationquestions@mh.ohio spelled out.gov, and we can follow up with you. Next question from Beverly Young. Where is the casino money for addiction treatment services showing up in the budget? We have a Rotary line item that it will be appropriated in the budget bill. I know it's here. Yeah, we actually have two Rotary line items, one that reflects our administrative costs, including any prevention spending that we do at the statewide level, and then the subsidy line. So that will be transparent in the budget document when you see that. I don't have the line right now, but we can provide that. I mean, that's available. Is there a clearly defined enrollment and opt-out process for clients in health homes? Teresa, your question is for the client, to the extent that they are eligible for health home services, they will be auto-enrolled to receive those services through processes between the Community Mental Health Center as the provider and the state agency. So it should be a seamless sort of augmentation or opportunity for the client. If they wish to disenroll from health home, then they can indicate their interest in doing so to the provider, and then ultimately the disenrollment has to occur at the state level at the state Medicaid agency. But we do have a defined process. I think one of the lessons that we've learned so far in the health home implementation is that there are some targeted changes that we want to make around the enrollment process just to make it a little bit more streamlined with the providers to make things easier. And so we will be communicating that to providers and working through that as we get ready for statewide implementation this summer. Let's see. Steve, you've talked about treatment, transitioning people, intervention and treatment of criminal justice. Where is all of this prevention, which the red-headed stepchild twice removed? Same dollars, no dollars, not a priority. Steve, legitimate question. We have, as I said, 100% funding approximately in our general revenue fund, and we have developed some creative strategies around the initiatives I outlined today. With that said, I think that there is certainly room for additional prevention and wellness opportunities. Ironically, we're continuing to investigate some potential in this area, even though it's not anything that we have ready for budget introduction. And so I think this is an area, as we come together as a new agency, there's interest, a lot of interest in placing more focus on this, particularly in light of some of the tragedies that have occurred in Ohio and nationally in the last year. And so, this is important, and the fact that it is funded at flat funding, you should not read into it that it is not a priority. So we'll look forward to working with you on that. What is the total dollar increase in GRF? Junie wants to know. Total GRF increase, if you hold just 1 second, is about $500,000. Is that true? It's very small. It's a 0.2% increase from 13 to 14, and a 0.1% increase from 14 to 15. But as we've talked throughout this presentation, there are opportunities that we are going to be able to execute that involve other ways to bring resources into the system, and so we will move forward to do that.
We have just lost the question pane.
It's right there.
Oh, there it is.
The questions pane moved around. Would love to know if you could provide listeners logged in today with CEE 1 continuing education credit for listening. I don't know that I'm worth any continuing education requirement, but thank you for the suggestion. Charlie Neff just says thank you. You're welcome, Charlie. We're all in this together. LPCCs and LISWs can already do alcohol and drug addiction services, so Joseph was making a point there.
And that is, if that's within your scope of practice.
Yes.
And I just want to point that out for the people out there. It's not automatic.
And then finally, can you speak to the possibility of SED health homes or plans for SED health homes? That is severe emotional disturbance for children. The federal requirements around Medicaid health homes, however states elect to design health homes, are categorical in that you have to, if you bring up a health home service, you have to make it available to both adults and kids. And with children, there are some special circumstances that we're still really trying to identify and unfold. So we had a really great event January 14th. We had 147 folks from across the state come together. We brought in some national experts to talk about health home implementation. And one suggestion that was made by a provider down in Cincinnati that day was for us to convene a group of child-serving entities or child advocates, including child welfare, including juvenile justice, to say, hey, how could we make some of the health home offerings for Ohio for youth as meaningful as possible? And so Angie Berger-Furd and others who are leading out on our health home efforts are actually going to be moving forward to schedule that. So to the extent that you are interested in that, maybe send us a quick note and we can make sure that you get added to that list when it is. How will we be able to go statewide with health homes by July 1st if there aren't enough already? Will clients be auto-enrolled in existing health homes? Presha, the answer here is we only have health homes to the extent that we have providers who are interested in becoming health homes. And so if we have a specific area of the state where there is not a provider who's articulating interest in becoming a health home, we will not have it available in that area. Our goal is to have statewide availability, even if all providers do not want to become health homes in July. If you know, in mass, a group of providers in a specific area don't want to move forward, we're not going to force sanction for those providers. Also, if you have two providers in a community, let's say Hancock County, you've got two. One wants to become a health home, the other one does not. The individuals who are enrolled as clients with the provider that's going to become a health home, they will be enrolled in health home. The others will not. But they could elect, if they wanted health home services, they could go across the street to the health home provider, you know, over a period of time. So that is evolving, but we're not going to try to force anyone to do anything that they don't want to do. Corey has a question. Do you have a rough estimate of the amount of the annual administrative cost savings that you will believe will be directed to community innovation? Corey, yes, the answer to that is $1.5 million in GRF in each year of the biennium. We've got a little bit that we would anticipate from Rotary dollars, but we're not directing that into the GRF line because we have the ability to spend that in subsidy already the way those line items are configured. And I thought we were getting toward the end, but there's more questions coming. David Brown, now that even more Medicaid dollars will be available, how will the state audit the providers? You know, interesting question. As we are consolidating as a single agency, the Department of Job and Family Services and Medicaid are in the process of untangling themselves two separate agencies. And so the surveillance and utilization review function that goes with Medicaid, because I think that your question is related to Medicaid, will be under the purview of John McCarthy, who's the state Medicaid director. So I think he will undoubtedly in the next year articulate his vision for any changes that he would like to see for the overall program integrity related to Medicaid. How we are a part of that or how local partners are a part of that, you know, that remains to be seen, but I know that will be on the Medicaid work plan. Okay, last one, not a question. D&E counseling, hello Youngstown, would like to be added to the list Tracy just mentioned about notification of a meeting to convene child serving agencies regarding health homes. yeah, we can definitely do that. So we'll follow up with you. All right. We still have 203 folks, so we've lost about 350, but certainly appreciate your participation today, and we will have this available online on our consolidation website. Appreciate your interest, and look forward to working through all of these details with you between now and June 30th.
No more questions. All right. Well, then that ends the webinar. We're going to go ahead and end the webinar. As Tracy said, look for this on the website by tomorrow. Thank you.